And I'm Michael Wang, Emeritus Professor of Clinical Psychology at the University of Leicester in England, United Kingdom.
Right.
So thanks very much for agreeing to have this discussion. I want to start by asking you what you think is the definition of an adequate anaesthetic.
An adequate general anaesthetic?
Yeah, general anaesthetic. Yeah.
Well, from my perspective, the goal of general anaesthesia should be that a patient is insensible, so that they are not aware of what is going on, that they are immobile such that the surgery can proceed, that they are safe, and that they are, so that would include things like hemodynamic stability and stability of various vital organ functions, and that doesn't just include things like blood pressure, heart rate, breathing, temperature, fluids. There are various aspects that are all, for me, part of a good general anaesthetic that are independent of the brain. So that the brain is the target organ of general anaesthesia, but general anaesthesia includes the whole body. And in relation to the brain specifically, we aim for somebody who is safe, insensible, and who's not experiencing a lot of noxious stimulation, because I think that noxious stimulation, even without consciousness, can potentially be deleterious.
What do you make of those anaesthesiologists who seem to be quite happy with an endpoint of amnesia?
I think that's within the realm of debate. I have a perspective. It's one could argue that it's a philosophical perspective. I think that having a negative experience for me is philosophically unacceptable. So I think that if one argues, you can have a week's worth of suffering, and at the end of that week I'll give you a tablet and you'll forget the whole week's worth of suffering that you've had. For me, that doesn't seem reasonable. I think that what we experience in our lives in real time as human beings is what we experience, and shouldn't be judged through the prism of retrospect and saying, our experience is judged in the present. We as humans live life in the present, and I don't want to have any moments of suffering in the present, and I certainly don't want those humans who are under my charge to have moments of suffering in the present. So although I think that amnesia is a necessary condition of general anaesthesia, I do not think that it is sufficient. I think that if somebody is to be awake during intended general anaesthesia, it's preferable if they're awake without suffering. So there are levels of there are goals of the best general anaesthetic is one in which somebody is completely insensate, they're unconscious, they have no evidence of noxious stimulation getting through, there's perfect conditions for the surgery, they wake up clear-headed without any pain and with minimal physiological perturbation. So that's the goal to which we aspire. But there are within, if we fail in achieving that, there are degrees of failure. So one of which, if somebody has a brief episode of waking up during an intended general anaesthetic, and the anaesthetist or anesthesiologist immediately notices that and then administers more anaesthetic medication, that is fleeting awareness which might have no negative consequence to the patient. They might not remember it, and in fact we might even tell patients in advance. Sometimes you might have a period of brief waking up, and hopefully we'll recognize that and treat that appropriately. The worst cases of unintended awareness during general anesthesia are where patients become awake, and they're unable to indicate that they're aware and awake. So typically because there is pharmacological muscle relaxation. But I think that theoretically it's even possible without pharmacological muscle relaxation. We can talk about that briefly. And they're unable to move, they're distressed, they may be afraid, they may be panicking and unable to communicate that. They may be in extreme pain with them feeling the surgical incisions and what's going on, and they might have inadequate analgesia. So even having adequate analgesia and all of that is preferable to having inadequate analgesia. These are all gradations of badness. You know, and I would like my patients to be spared all of them.
Sure.
And you know, I think we can discuss which is worse than any other. But from my perspective, somebody having a very unpleasant experience and not remembering it when I'm entrusted to take care of them is not acceptable. And in fact, the real answer to that isn't whether I think it's acceptable or when any of my colleagues think it's acceptable, because I think we just have to ask our patients would they find that to be acceptable. And those whom I've asked, and I have asked, have not thought that that would be acceptable. It is my strong opinion that the overwhelming majority of our patients would not feel that that was a reasonable target for general anesthesia. So who cares what I think? I could say, oh, it's absolutely fine. They won't remember anything. But if they're not on board with that, well, too bad what I think.
And of course there's also the Bristol survey, I don't know if you know about that, where anesthesiologists themselves were asked, you know, if you had that option,
would that be okay for you?
Which would you choose, oblivion or amnesia? Of course they all chose
oblivion. Absolutely.
So there seems to be a double standard operating here. There we go. So thanks for that. I'm sure you're aware that Robert Sanders, Jamie Slay have talked about disconnectedness, and now more recently J.D. Pandit has been talking about dysanesthesia. So these represent a kind of midway point or a partial loss of consciousness, but not full loss of consciousness. What's your view of that? I mean, I say that in the context that J.D. has almost suggested that it would be acceptable for that to be seen as a target for anaesthesia.
Well, consciousness and unconsciousness are, you know, complicated terms, and these are, first of all, lots of disagreements about what these actually mean. These are subjective human experiences, and I can never know what conscious experience you're having, and you can never know what conscious experience I'm having. We can only describe them to each other as best as we can. I guess the problem I have with that, again philosophically, is that it might be completely acceptable for somebody to have, for example, internal consciousness. So when we dream, we are conscious. You know, and it's an internal form of consciousness. So it is conceivable that you know, perhaps I would be asleep and I would have a spinal anesthetic and I'd be having surgery on my leg, and I would concurrently be dreaming about a holiday in Helsinki. I'm clearly having some sort of conscious experience which is unrelated to the surgery that's going on my leg. And you know, maybe I'd even have some lucid dreaming, and I'd even be, I don't know what my awareness would be with that, but would be, you know, a higher order of self-awareness than you would have just with normal dreaming. I think the problem I have is that because consciousness is, as I say, a very subjective experience, it is possible that you could say somebody is appropriately anesthetized even if they could follow simple commands. You could say, well, they're probably not in pain, they're probably not aware of what's going on surgically. But I'm using the qualifier probably. I'd be much more comforted if they weren't interacting with me at all.
Exactly.
Because that would give me more confidence
Sure.
that they were not aware of the surgery. It would be possible that they could, for example, squeeze a ball and at the same time not be aware that of a surgeon, that she was wielding a scalpel and cutting away
Sure.
at the ligaments.
Yeah.
But how would I know for sure?
Sure.
I guess I could ask them and say, well, squeeze the ball if you're feeling the scalpel, and it would give me some evidence.
Yeah.
But the target for me would still be, as much as I could ascertain, that evidence of unconsciousness, and all we have is evidence.
Yeah.
The fact that I'm not interacting with you doesn't guarantee that I'm unconscious.
No.
And especially if I'm pharmacologically paralyzed, then my means to interact with you is substantially curtailed.
That's right.
Because I can't move.
Yeah.
But even if I can move, I might be unable to initiate movement for some reason. There are,
Sure.
one can certainly. I've had patients. I'd give you one anecdote which was very disturbing to me. I had a patient who had a hysteroscopy, and she received an anesthetic, sedative, hypnotic agent called dexmedetomidine and an opioid medication called remifentanil. And this wasn't one of my patients, but I spoke to her afterwards, and during the procedure she didn't move. The procedure went ahead uneventfully, but she was very uncomfortable during the procedure. She had pain. She felt humiliated because of the nature of the procedure.
Sure.
But for some reason she was unable to initiate movement, and she couldn't explain that.
No.
I can't explain that. She had no pharmacological,
no
muscle relaxant,
Yeah.
and yet the only thing that seemed to have been taken away from her was agency.
Yeah.
She couldn't communicate, she couldn't initiate movement,
Sure.
but she had full awareness of what was going on, and she encoded memories.
Yeah, absolutely.
So, I think it's unpredictable. We can't be certain about what people are experiencing,
Sure.
and we have to do our best.
Yeah.
But I think that even with doing our best, we will have failures.
Sure.
And that's also something we need to be transparent with patients about. That occasionally, even with our best efforts, we won't get it right.
No. Okay.
And that won't necessarily be because, usually it will be because we did something wrong, but not always.
Yeah.
Usually it is because we've done something wrong. I do think that, actually. I think it's often because, something has happened that we haven't administered sufficient anesthetic agent. Something has gone wrong.
Sure.
But that's not always the case.
Yeah. Moving on, what do you make of spontaneous movement in an unpharmacologically paralysed? In other words, there's no neuromuscular blockade, and
Right.
Your patient is lying there on the table, and there is spontaneous movement.
So what sort of spontaneous movement? Breathing?
No.
Or no?
So movement of a limb, let's say.
Apparently purposeful or not apparently purposeful? Because there is a difference. So I think that, for example, if you cut into somebody and they're not pharmacologically paralyzed, movement is pretty common. And most of that will occur when beyond loss of consciousness. Usually that indicates that perhaps you don't have enough analgesic medications on board. Certainly you can increase the anesthetic agent that you're administering, whether it's a volatile anesthetic or intravenous anesthetic, but it is unusual that the movement will indicate awareness.
Okay.
Most of the time when people move in response to a surgical stimulus, they're usually unconscious, although I don't know that for sure. I'm guessing because, as I said earlier, I can't tell what someone's conscious
but you're
experience is.
saying that your common response to that as an anesthesiologist would be to either deepen the anesthetic or possibly give more analgesic.
I would usually do both.
Yeah.
Because even though my guess would be my best guess, and based on how I understand the pharmacology of those drugs, that at very low concentrations, they tend to engender amnesia.
Sure.
Subsequent to that, they tend to
Yeah.
to render
Yeah.
a person unconscious and perhaps
Yeah.
not aware of the environment. And then at a higher concentration than that, and it's mediated maybe mostly at a spinal cord level, which also there is an effect on higher centers in the cortex and subcortical areas. But abolishing movement typically occurs with higher concentrations of anesthetic agents. I would nonetheless be conservative, and if a patient moved, I would both increase the agent that produces unconsciousness and provide more analgesic agent.
Thanks. You wouldn't reach for the muscle relaxant.
Oh no, that's not my practice.
As some of your colleagues would.
Well, I think it's complicated. I think sometimes they are concerned about, so their motivation for doing that is, it's alarming to them. Suddenly their patient is moving and the surgeon is getting uptight, and they're actually worried about the safety of the patient from a surgical standpoint. Having a patient who's having delicate surgery start to move is not very safe for the patient.
Sure.
The patient can have harm from that.
Sure.
The surgeon can be at a delicate part in the operation, and she can cut through a structure that she would obviously not wish to cut through. My response to that is, I'm likely to achieve immobility more rapidly with propofol than I am with
that's a very good point.
with the muscle relaxant.
Absolutely,
So even from the safety target, a potent intravenous hypnotic agent is more likely to achieve immobility quickly.
Sure.
I mean, you've received a muscle relaxant. It didn't paralyze you in an instant.
No.
So if you were moving in response to a painful surgical stimulus, even with our even if I gave a massive dose of rocuronium, you'd still have a good minute where you would be moving. And I think with propofol you can probably achieve immobility more quickly.
Sure.
So I think that there are various reasons that a muscle relaxant's not the best answer. And also, if they were awake, that would be a terrible thing to do to them.
Absolutely. Would you ever consider trying to communicate with the patient?
I think that would be a really good thing to do. In honesty, I think my response there would be, oh my goodness, the patient's moving. It's a delicate part of the surgery, and although I absolutely think talking to the patient, reassuring them...
But what if it wasn't a delicate part of the surgery?
Yeah, then that would be a really good thing to do. But it's often the way in which that is communicated to the anaesthetist or the anesthesiologist is they're not necessarily watching the patient at that point in time, and their surgical colleague says to them, the patient's moving, in a rather alarmed tone.
Absolutely.
So you're not necessarily able to assess immediately, is it a delicate part of the surgery? Do I have the luxury of communicating with the patient, reassuring her? And so you're going into a sort of a reflex response mode.
No, I understand.
So you're talking about in an ideal world, absolutely. So I could say, if it were you, I'd say, Michael. I'd say to my surgical colleague, it's all right, just stop what you're doing for a while. Michael, you might be waking up. I'm with you. I'm keeping you safe. I'm about to give you some more medications. In fact, I'm administering them right now that will help to alleviate any pain that you might be feeling, that will deepen the sleep that you hopefully are experiencing, and I'll make sure you're more deeply unaware. But I'm not sure I'd have the presence of mind to do that.
Yeah, that's absolutely, from my point of view, the right response. However, I'm giving you marks here. However, it neatly brings us on to what for me is becoming a very significant issue, and that is the politics of the operating room.
Right.
To what extent do you think your colleagues, maybe yourself, feel under pressure to perform competently in the eyes of the surgeon?
I think it's the pressure is much more on my junior colleagues. I think that for me, I've been in the game for a long time. I have sufficient grey hair quotient and all the rest of it. So the pressure on me is minimal. But I think on trainees, on junior colleagues, on CRNAs, on nurse anaesthetists, those who are experienced clinicians have much more latitude when you've built I think it's really important to build trust in a team. When teams work together, when they know that all the members of the team are competent and you've communicated for a long time, the whole dynamic changes.
So I mean, I've been in theatre when the anaesthetist has said in the UK to the surgeon, "Can you just stop for a minute?
Sure.
We need to stop." Obviously, when I've been in theatre with Ian, it's quite common for Ian to start speaking with the patient, and of course the surgeons that he works with
are used to that.
Are used to it, absolutely. I have to say that I think there needs to be a turnaround in the culture where it's acceptable for anesthesiologists in America as well as in the United Kingdom and all over the world to start attempting communication with what, from a surgical point of view, appears to be an unconscious patient.
Right. It's
just to check.
It's complicated because many of the surgeries these days. So, for example, thinking about the isolated forearm technique, many of the surgeries these days are done with patients. So, for example, all the heart surgery I do, patients' arms are strapped to their sides. There's no way I can do meaningfully the isolated leg. But even that you've got the tray all the way over. You've got no access to the leg. You can't do. You actually physically don't have access. There are many types of surgery today where patients are mummified in their preparation, and it's not practical. So some of the objections, it's not. I have no intellectual objection, and for many of my surgeries I do isolated forearm, but for many it's simply not practical. Or the hind leg of a patient. It's not the foreleg. Is it?
You actually use the isolated forearm clinically?
I do. I do.
You have to clone this.
No, I mean it's not. But there are really surgeries where it's not feasible. And most of the surgeries for which I provide anesthesia, patients' arms are strapped to their side. So it really takes that possibility out. But I don't. I don't paralyze those patients.
Sure, which is great. But I'm wondering if there's any room for compromise on whether a conversation between a surgeon and an anesthesiologist could result in some way of getting around that.
Oh, I mean, undoubtedly. I mean, I think that the whole notion of this is my emporium, that's your emporium, or but never the twain shall overlap is silly. I mean, we're all there for the patient, and it's all about communicating, building teams, and I think that we at our institution, because we've conducted multiple studies into intraoperative awareness, our patients are aware of it much more so than at other places, and they're more sensitive to it, and they understand that this is a big problem. When they've had patients who've had intraoperative awareness, we've provided feedback to them about it, and they're looped in.
Sure. I want to move on now to ask you some questions about NAP5.
All right.
So the National Audit Project number 5 was an audit project conducted by the Royal College of Anaesthetists and the Association of Anaesthetists of Great Britain and Ireland. And this was an audit carried out over a 1-year period in the countries of the United Kingdom and the Republic of Ireland. And it was rather unique because of the fact that the college gained access to every single hospital in those two countries, and all of the data was reported directly to the college. And because of that fact, a very large number of operative procedures were covered in the millions. And of course, one of the issues here is that the incidence of reporting was found to be very much lower than the standard Bryce interview approach incidence that we already have in the literature. So instead of it being around 1 in 600. It comes out in the many thousands. I think the average was about 1 in 19,000 over all the procedures. I just wanted to start by asking you what your opinion was of NAP5, and in particular what you make of the way in which certainly I have noticed that in the United Kingdom many anaesthetists are using NAP5 data as an excuse for dismissing accidental awareness as a significant clinical phenomenon that we have to worry about.
Well, I think first of all, to start with a Lord Daytree comment, and to say that it was a very impressive project, and to conduct these national audit studies where you really cover every hospital in Great Britain and Ireland is impressive in its scope. It's ambitious and very informative, and like the other national audit projects, NAP5 yielded valuable information that continues to inform aspects of practice. It is, as we were discussing earlier, that one of the difficulties with intraoperative awareness is that it's not something that you can ascertain has occurred through, I can't put some sort of monitor on your head and say, well, he's experienced awareness and he's going to remember it, or he's not going to remember it. This is something that we depend on our patients to tell us about. And for various reasons, our patients don't necessarily inform us that they were that they had episodes of being awake during their surgery, after their surgery. For one thing, they might not remember that they were awake during their surgery, which is probably the most common, or one of the more common reasons, because most times that patients wake up during surgery, they don't necessarily consolidate episodic memory. But even if they do remember, initially they're confused about the experience, they're wondering, when did this happen? They may be focusing on other things. They often tend not to report this voluntarily.
Yeah.
They certainly often don't report this immediately.
Yeah.
So I think that almost by definition, this will be an under-detected problem.
Yeah.
The extent to which it is under-detected by any method,
Yeah.
I think, is debatable. I think usually when a patient reports that this has occurred, I would say most of the time it has occurred. Well, certainly their perspective that it has occurred. And to say when it has occurred is also pretty difficult. You can say, oh, well, it doesn't sound like this was during the surgery. It sounds like it was, some other time. These are difficult judgment calls.
Yeah.
But as I say, I think that the key point here is that this is a problem that can be very devastating for patients when it does occur. Some patients describe it like the sensation of, not that they necessarily would have experienced this, but they imagine it to be similar to being buried alive.
Sure.
So a very distressing experience, and not only are they buried alive with inability to communicate with having that sensation, they're also in pain, unable to communicate that, they're afraid.
So in fact, you've got actually two cohorts within those who don't spontaneously come forward and complain or report, which of course NAP5 is relying on.
Right.
On the one hand, you've got those people who certainly had awareness experiences and have explicit recall, but they do not consider what they remember as being terribly important. In other words, they are trivial memories without significance or salience.
Well, they think that.
Yeah.
Many people are stoical, and
Yeah.
they I've just had major heart surgery. I'm not going to talk about the fact that
and particularly men.
Yeah,
That's a particular issue for men.
society puts various pressures on us and
And
expectations, and we don't want to appear to be
absolutely. And then at the other extreme, we have the really traumatized people,
right,
who actually won't even go near their family doctor after this has happened, let alone the anesthesiologist that did it to them.
This isn't the only trauma that people conceal and keep to themselves.
Absolutely.
I mean, Many people have many serious traumas.
Childhood sexual abuse, for
is a very germane example. Not only childhood, adult sexual abuse. I mean,
absolutely.
people keep things to themselves for complicated reasons,
Yeah.
and the same applies to this particular trauma. There's no reason why we would expect that everybody would say, "Oh, I've had this awful experience where," some people will and some people won't, and maybe it's the majority who will not feel comfortable talking about it. And,
absolutely.
And they feel you feel grateful to the clinicians who've taken care of you, and you know you're alive, you've done well, and then you
don't want to rock the boat.
You don't want to come across as being ungrateful,
absolutely.
And it's very complicated. I mean, these are not straightforward reasons, but I think that everybody would agree that NAP5 yielded very valuable information, but it almost certainly under-detected the...
It is not a valid measure of incidence.
So I'm curious though, since everyone knew that it would be an underrepresentation, what was the practical point for doing it? Because it was a huge project.
Right. Well, I wrote an editorial about it, and the editorial, I think the title of our editorial was "Under the Rate or Under the Radar."
Yeah, I remember.
So we specifically, George Mashur and I addressed that question head on, and we said it's entirely predictable that this would have under-detected the problem, and we know that from our own research. So, for example, we published another study where we had two methods of detection in the same patient cohort.
Yes.
So this is very, very important. This is in the same patient cohort, that when the patients reported themselves compared with when we subsequently contacted them and asked them direct questions, we were detecting 10 times more through the method of contacting patients than through self-report. So we knew already, we had good empirical evidence that this method would yield under-detection of the problem. It's not, this came as no surprise to us.
Absolutely. And can I just say that I, along with Jackie Andrade, were from the outset members of the NAP5 panel. We were present when all the discussions took place about design and methodology of the project. We knew at the outset that many of the anaesthetists involved in the panel had thoughts, maybe they hadn't articulated them openly, but had thoughts that NAP5 would find a much lower incidence. And this comes within the context of average estimates. So in other words, there have been surveys, as you know. You ask anesthesiologists, what do you think off the top of your head is the incidence of accidental awareness? And most British anaesthetists will say off the top of the head maybe 1 in 10,000. And you say to them, well, did you know that the empirical evidence using the Bryce interview shows that it's around 1 in 600, and that's pretty consistent? And most of them are in denial about that data. So we have the audit project, and it's my perspective that many of the anaesthetists came to that project with the view that this was an overestimate, 1 in 600, and that NAP5 would find the true incidence. And I've had many arguments with panel members, and we started out from the very beginning, and I predicted that we would get very low estimates like you, and I made the point that I wanted from the outset to say that this is not going to be a measure, a true or valid measure of incidence. But inevitably, that's the way it's being used.
So I think this brings up a cultural political point that goes like this. One of the reasons I wanted to analyze the not valid aspect to the expert system was that not that there would be an absolute way to have a more precise classification, but rather the need for transparency. Because when Peter Siebel published it, one of his criteria was to publish all the reports and let the reader decide, and yet it evolved to where they weren't being published. And with the Zhang paper, like he made a comment about different cultural aspects of Chinese patients reporting stuff that clearly had nothing to do with the surgery, and that's fine, but it's important to objectify that stuff. And over the course of my involvement in anesthesia, the recurring theme I see is with new anesthetic developments and issues, there is a tendency in the field by the experts and the rank and file to shift to positions that tend to underestimate awareness. Whereas now we are getting experts very concerned about delirium and decreased survival as a justification for light anesthetic techniques and across-the-board paralysis. That was the same rationale in the 40s, 50s, and 60s when truly people were dying from deeper levels of anesthesia. But then that justification was brought forward when we got sophisticated interventions in cardiac physiology, etc., where we could keep them deep even though they were critically ill. So there's a tendency in our field because it's tough to be in the OR, it's tough to deal with unhappy patients, where we justify light anesthetic techniques and paralysis. That seems to me to be the theme that needs to be addressed. And you do it, you're fabulous, but you're in the minority. We get a lot of expert opinion now about concerns over delirium, decreased survival, and the need for light anesthetic techniques with across-the-board paralysis.